Hello everyone, I'm Pratiksha Arya, physiotherapist, Cardio Neuro Center, CTVS, AIMS. My topic for today's presentation is physiotherapy in ICU acquired weakness post COVID 19. COVID 19, whose full form is Coronavirus Disease 2019, is caused by SARS coronavirus 2. It's a novel virus, which means it's a new virus which has mutated, and we are trying to study about the virus and the problems it is causing in human beings. The clinical presentation of this disease varies from asymptomatic to severe clinical conditions characterized by respiratory failure, multi-organ dysfunction, and sepsis. The total number of confirmed cases worldwide currently is 2 crores 76 lakhs 39,263, out of which India accounts for about 44 lakh cases. Out of the overall deaths worldwide of about 9 lakhs, India accounts for about 74,000 deaths. Since this virus is still under study, still we have to know so much about virus, but the data which is coming from all over the world. So the current data I have is that about 3 to 10% of patient population affected by this virus is in requirement of ICU admission. Out of these people, the people who undergo critical illness is variable according to the countries and ethnicity. The data varies from 10% to 40%. How many people have actually out of this critical these critical illness people, how many people have actually landed up in ICU acquired weakness? Still we don't have the data, but we have a few individual case studies and a group of studies which have been showing that the people who undergo critical illness because of COVID-19 develop ICU acquired weakness post that. What is ICU acquired weakness? It develops as a secondary disorder while patients are being treated for other life threatening conditions. In the present context, it is a person who has been infected by COVID 19 develops a multiple organ failure, multi system affection, and ultimately critical illness because of that. And because of that critical illness, the patient develops weakness. ICU acquired weakness is clinically found as a huge spectrum of disorders. On one hand, it can be a mild weakness of some peripheral muscles, whereas on the other hand, it can be complete quadriplegia with ventilator dependence. The isoacquired weakness is typically a generalized pattern of weakness symmetrically involved, which affects proximal limbs more than the distal muscles, and it also affects the respiratory muscles. The facial and ocular muscles are generally spared, the muscle tone is decreased, and DTRs are generally normal or decreased. The clinical differentiation of ICU acquired weakness has been done as critical illness neuropathy, myopathy, neuromyopathy, and severe disuse muscle atrophy. These are basically differentiated on the basis of EMG and CV findings, the muscle biopsy findings, and in terms of prognostication, critical illness myopathy is said to have a little better prognosis as compared to the other two forms. Prevalence of ICU acquired weakness in critically ill patients. There have been recent systematic reviews which have mentioned that about 43% of the people who develop a critical illness because of various reasons may land up in differential levels of ICU acquired weakness, and most cases it has been seen that diaphragm dysfunction may be more often affected than the limb muscle, may be more often present as compared to the limb muscle weakness. The pathophysiology, I'm not going to delve very deep into the pathophysiology aspect because I want to spend more time on the physiotherapeutic assessment and treatment part, but just to brush of it, it is basically divided into two parts: the muscle atrophy and the muscle dysfunction part. The atrophy part comes from the Disbalance of the catabolic and anabolic hormones. The catabolic hormone secretion increases. In addition to that, the immobilization, disuse, unloading due to mechanical ventilation in itself lead to deconditioning and increase the muscle atrophy. The factors which are responsible for muscle dysfunction are structural muscle alterations, microcirculatory disturbances, bioenergetic failure, inadequate autophagy activation, membrane and ion channel dysfunction, and central nervous system involvement. The risk factors have been basically divided into parts: the non-modifiable and the modifiable risk factors. We would talk about modifiable risk factors towards the treatment part also, because these play an important role in the prevention as well as management of this condition. But first, talking of the non-modifiable, the first and foremost is the demographics: the female sex, the older people more than 50-55 years of age, with the especially with pre-morbid obesity, are considered high risk patients for development of critical illness, the way they have been considered high risk patients for development of COVID-19. Therefore, we can deduce that the people of this demographic may have a high chance of development of ICU acquired weakness if and when they develop COVID-19 disease. Then, talking of the severity of illness, the higher illness severity score, systemic inflammation or sepsis, multiple organ failure, prolonged mechanical ventilation, prolonged critical illness, high lactate levels have been considered non-modifiable risk factors. The important risk factors, modifiable risk factors, first and foremost, hyperglycemia has been considered a very important modifiable risk factor. The emergence of parenteral nutrition, drugs, especially neuromuscular blocking agents combined with corticosteroids if given for more than 48 hours, plus immobility, which in itself is an additive factor for for increasing the risk of intensive care unit acquired weakness. Then what are the complications? What kind of complications the patient may land up with if the patient develops ICU acquired weakness? If we talk of the short-term complications, ICU or hospital mortality, I have mentioned in my references, there has been a study which says that the ICU mortality can go up to 50% in critically illness patients who have developed ICU acquired weakness. And there is a special mention of a study I would like to do. It was done in heart transplant patients, that they have a 50% chance of mortality if they develop ICU weakness after developing a critical illness post transplantation. Then increased mechanical ventilation, because patient would land up in a vicious circle. The mechanical ventilation would lead to ICU weakness, which would lead to weakness of diaphragm and respiratory muscle, which would again lead to increased requirement of mechanical ventilation, and the patient gets tangled in this vicious circle. If we talk of the long-term complication, the post-ICU mortality, and very important, the current project which is being done by APTA, the PACER project, the post-acute care exercise rehabilitation, they have given the terminology of PICS, post-ICU syndrome, in which they have mentioned that especially the COVID patients are at high risk of development of PICS, which is a decrease in physical, respiratory and mental capacity post discharge from ICUs. This may be an important long-term complication of ICU acquired weakness. Now, very important for us, the onus of diagnosis of this condition lies a great deal on physiotherapists, because we spend maximum time with the patient in terms of the exercise part, the volitional activity of the patient, the active or the passive mobilization of the limbs. Therefore, it is our responsibility to check for the earliest signs of weakness which are developing, because early assessment, early diagnosis plays a very important role in management of this condition. So the assessment has been basically largely divided in four parts: volitional, functional, volitional testing, the electrophysiological testing, imaging, and biopsy. In volitional functional testing, the MRC sum score is considered the gold standard non-invasive bedside testing, which is a very reliable and highly valid test, at least up to a score of 0 to 3, and it's an very good overall estimator of motor function. MRC is basically divided in six categories: 0 to 5, where 0 represents no contraction, 1 is contraction without movement, 2 is movement in gravity eliminated plane, 3 is movement against gravity, 4 is complete full range of movement against resistance, and 5 is normal muscle strength, just like our MMT. uh, Six group of muscles, three in upper limb and three in lower limb, which are functionally important muscles, which is basically shoulder abductors, elbow flexors, wrist extensors in upper limb, and in lower limb hip flexors, knee extensors, and foot dorsiflexors have been considered, and this test is done bilaterally. These muscles have been considered the most easily accessible and functionally important muscle in a critically ill patient, which we can easily test for. If a patient gets a score of less than 48 out of 60, it is considered a significant weakness, and a score of even less than 36 out of 60 is a case of severe weakness, which should be appropriately and timely informed. uh, and since this test needs cognition and cooperation of the patient, so it is imperative that in every 24 hour there should be one off sedative period, where we can the patient can come off the sedation, and voluntary muscle testing can be done if possible. Then in the cases, again we have handheld dynamometry, which is again also a gold standard. It is a good, valid, and reliable method of testing, but it may not be a good reflector of global muscle strength. Then to overcome the okay, before the next thing which I was talking of, the functional test, the individual muscle testing which we do, individual muscle group testing which we do, may not be a good reflector of the functional activity of the patient. They may have good muscle strength, but they may not be able to utilize the complex muscle functions to do the functional activity. Therefore these functional tests play an important role. But the issue with such kind of critically ill patients, especially in the ICU environment post corona epidemic, these tests are really difficult to perform. And 6-minute walk test especially is a good test, but again it is generally performed in later phases of rehab, like if the patient is being shifted to ward from ICU, or maybe patient is shifting for home care from the wards, then it is done. Then to overcome the need of cognition, cooperation of patient, we have electrophysiology, which can be done. The electrophysiological tests like EMG, NCVs can be done in a patient who is not even awake or not cooperative or compliant enough to do the volitional muscle testing. But then these tests are they require the expertise as well as the equipment which is specialized, which may not be always available. Then direct muscle stimulation is a very good tool in a physiotherapist's hand, where the physiotherapist can easily use the direct, or that is intermittent galvanic, or the Faradic currents for stimulation of the peripheral muscles, and see if neurological or muscular level of involvement of the motor unit is there. It is easily accessible method, easy to perform, and non-invasive kind of method, but yes, it definitely requires a level of training. Then if we talk of the imaging, the ultrasonography is in the recent times it has developed as a very good bedside, easy and quick method, and a method which can be repeatedly done on a critically ill patient who is bed bound. It basically utilizes the muscle cross sectional area to signify about the muscle strength, but definitely the lack of standardization in terms of inter-rater reliability is still there, so it needs to be worked upon. CT and MRI are definitely a step further for diagnosing and assessing, but not cannot be done on a very ill patient who cannot be moved out of the ICU. Nerve and muscle biopsies play more of a research kind of additional role, and they have very less clinical role. It's more of a research or a diagnostic role, differentiation between CIM or CIP. Then assessment of respiratory muscles. Mainly the diaphragm is assessed here. To assess the volitional functional to do the volitional functional testing of diaphragm, the we can check the maximum inspiratory and expiratory pressure in an intubated patient in a ventilator, or we can do it by simple spirometers in a non-intubated patient. And we can judge about the strength of the diaphragm and the expiratory muscles global strength. um, if we talk of the widely more the other methods which are other than the PI max and PE max, chest x-rays and ultrasonography of diaphragm are routinely used methods, especially in our ICUs, to rule out muscle diaphragm weakness or palsies. Chest x-rays are easily available. They can show the diaphragm position, but yes, they have low sensitivity and specificity related to the muscle weakness or palsy. The ultrasonography has a definitely advantage over x-rays. Relatively, they are inexpensive, no radiation, and better diagnostic outcomes, but they have limited value in assisted ventilation cases. Now we have assessed, now we have found that the patient is having weakness in the muscles, in the peripheral muscles, and or respiratory muscles, and there is no CNS or PNS cause behind it. Now what should be, as a physiotherapist, as prevention, what should be our treatment and prevention strategy? So the first thing to know about this condition is very important, that there is no specific treatment, only to diagnose early and prevent the modifiable risk factors is the mainstay of getting a good outcome. Especially in the form of minimizing the patient exposure to corticosteroids or neuromuscular blocking agents. Still, we have more data on these things, but tight glycemic control with intensive insulin therapy, keeping the patient between a glycemic control of 80 to 110 milligrams per deciliter of glucose, has shown to give very good results in prevention of ICU acquired weakness, maintenance of electrolyte homeostasis, and early rehabilitation and mobilization, which we are going to talk about in detail, is mainstay to the prevention as well as treatment of this condition. Then I would like to specifically mention about neuromuscular electrical stimulation. During my research about this topic, I found this article by Christina Rautzi from Critical Care 2010. It's electrical muscle stimulation prevents critical illness polyneuropathy, a randomized parallel intervention trial. It is considered to be the first RCT which gave about 45 hertz of biphasic symmetrical pulses of 400 microsecond duration with a 12 seconds on and 6 seconds off period, producing visible contraction in patients, and daily treatment duration of 55 seconds. And they have shown that it can rightly be used to prevent ICU acquired weakness in patients, as well as decrease the weaning time from the ventilator. Okay, now talking about the early mobility and mobilization, what I have tried to find out a study which has categorically divided the early mobilization phase into proper 4 phases of mobilization according to the stage and according to the functional level of the patient. It's an article by Chandrasekhar et al. From the American Journal of Critical Care. Early mobility and walking program for patients in ICU, creating a standard of care. what they have tried to do is, they say that beginning of the mobility program, when patient is they say that the mobility program should begin when the patient is minimally able to participate in therapy. Even if the patient is just able to do a little bit of active assisted exercises within bed, the patient's early mobility should start. The stable hemodynamic status and receiving acceptable levels of oxygen. They have mentioned that the presence of inotropes, presence of ventilator, presence of lines, and presence of intubation also should not be a hindrance to patient's mobilization. We need to prepare a team according to that, who should be able to manage all these equipments along with the patient, so that we are able to take patient in different stages of mobilization. It's a practical approach in managing patients requiring mechanical ventilation. It basically consists of 4 phases. They say that there should be an initial assessment to determine the phase of mobility in which individual patient lies, and the patient stays in that particular phase till the requirements to go to the next level are fulfilled. And if the patient deteriorates, the patient would come back to the previous level, and again patient would work hard in that phase till again patient becomes eligible to go to the next phase. So the phases in which they have divided their early mobility program is: phase 1 is bed mobility and exercises in bed till the patient is able to take weight on both his legs with maximal assistance along with an assistive aid. Once patient achieves this, patient can go to stage 2. The stage 2 is transfer to chair and initiation of walking re-education with assistive aid. So the patient should be able to take 1 or 2 steps with the assistive aid and should be able to transfer to chair with maximal assistance. Then if the patient tolerates that, and is then the patient is eligible to go to stage 3, which is increase the tolerance of progressive walking with assistive aid within the ICU itself. And once patient is able to achieve that too, the patient can go to stage 4, which is intense training with treadmill or ergometer also. The various physical therapy intervention strategies which we can follow during these stages of early mobility can be divided in terms of respiratory strategies, movement strategies, functional exercise strategies, exercise prescription, etc., depending upon the whims and requirement of a individual person. For example, if we talk of the respiratory strategies, we have to think of respiratory weakness because of mechanical ventilation, so we need to go for strengthening exercises in forms of IMT. Or if we are thinking of that we need to the patient needs to is having shallow respiration, or patient's dependent lobes have become atelectic, then we need to work on the spirometric aspects. If the patient needs secretion removal, then we need to work on the assistive cuffing techniques. It all depends upon the stage and requirement of the patient. Then range of motion. Due to the peripheral muscle weakness, the patient would definitely benefit from the range of movement exercises. It would depend. It's passive, active assistive, active, and then resistive, and finally we can go up till PNF diagonals for resistive training also. For functional mobility training, because of symmetrical weakness, patient may not, it's very much possible that patient's functional tasks are affected. So just training them in terms of single muscle strengthening may not help. Patient needs to use the cognition and the complex activity required for his ADLs. Therefore, we need to train patient for bed mobility, balance, transfer training, gait, stair negotiation accordingly. The exercise prescription and training in such kind of patients cannot be done in the traditional way. Definitely, it's so obvious. So we generally go for the response dependent management. The commonest example is Berg RPO. This brings me to the end of this entity known as ICU acquired weakness, and which has been compounded by this corona pandemic, since we are expecting more and since we are expecting a particular percentage of patients who would land up with critical illness, and we have data coming that people are also because of increased ICU stays, people are developing ICU acquired weakness. So It's just that I think the famous lines by Dan Brown in The Lost Symbol, the more the man learned, the more he realized he didn't know, are being proved by this COVID 19. The more we are learning about it, the more we are coming to know that still so much more to know about this virus and the consequences it is having on the human race. So, thank you very much for listening, and have a good day. Thank you.